We shall now go on to our next very eminent speaker, Dr. VINAY NANGIA, who is going to be talking on a typical case in angle closure disease.
I'm going to take you through a case of PACG, and every time that I deal with a angle closure glaucoma with elevated intraocular pressure, it's a great challenge trying to figure out what's going to happen to this eye actually. So this is a male who was 53 years old and came to us with complaints of blurring of vision in both eyes since the past 7 months. And he was on pilocarpine and timolol maleate in both eyes for the past year. The visual acuity was 6.9 in right eye and 6.9 also in the left eye. The anterior segment examination showed a Von Herrich's grading of 1, and there was posterior synechiae and sectoral iris atrophy in the left eye. The intraocular pressure recorded was 15 millimeters of mercury in the right eye and 29 in the left eye, and gonioscopy showed 360 degrees angle closure in both eyes. So these are the anterior segment measurements. The axial length was about 22.23 in the right eye and 22.40 millimeters in the left eye. The CCT was a little on the higher side for our country. The aqueous depth, that is from the posterior surface of the cornea to the anterior surface of the lens, was really shallow. It was about 1.64 and 1.59 right and left eyes. And the lens thickness was on the higher side, being about 4.58 and 4.59. You can see the appearance of the anterior chamber and the anterior segment. You can see the iris bombay in the right eye that is on the left side, and the left eye you can see the pupils are semi-dilated because of the changes in sectoral iris atrophy. So this is the appearance of the optic disc, and you can see we're really dealing with an end stage kind of PACG patient, and there was significant retinal nerve fiber loss, and you can see here that in the right eye on the heat map, the GSL only some part of it is still remaining, but the inferotemporal part, which is the part that undergoes maximum damage, that's all gone actually, and the deviation maps also tell you the same thing. And the left eye, you can see that there's even greater damage, even though the eye retains 6.9 vision. So the patient was diagnosed to have primary angle closure glaucoma, and we advised alpha agonist beta blockers and Diamox tablets, and he was not willing to undergo any surgical treatment at this point. He came back 3 months later. The intraocular pressure in the right eye was 24 millimeters of mercury. In the left eye, it had gone up to 60 millimeters of mercury. And then he was advised combined surgery in the left eye. He did undergo left eye cataract surgery and trabeculectomy. And 1 week post combined surgery, the intraocular pressure was 21 millimeters of mercury in the left eye. And then the patient was lost to follow up for this intervening period of 6 weeks, which we think is a very important period for taking care of the eye actually. So he did come back, and at that time, he also underwent the right eye cataract surgery and trabeculectomy. And the left eye intraocular pressure was found to be 30 millimeters of mercury, and he was put on drops again. On follow-up, in the right eye, he appeared to have developed a flat bleb with an intraocular pressure of 23 millimeters of mercury. And on massage, the intraocular pressure went down, but after an hour, it again came back up to the same levels actually. So we did bleb needling for the right eye, and that was done on the 24th of December, 2021. Meanwhile, the left eye intraocular pressure was continued to be on the higher side, and that, we did advise him further surgical management. So this is the appearance of the bleb in the right eye. It's the conjunctiva appears to be turning pale, and this is the bleb just post needling, and you can see the anterior segment OCT shows a large gap between the bleb and the sclera, and that is a part integral to the bleb. But the second photograph shows that on the adjoining sides, the bleb architecture in the conjunctiva, the development of the pores that has not yet formed. So we're not quite sure how this bleb is going to do over a period of time, and we're waiting for the patient to come back for a follow-up. And this is the left eye. So what we have is the pale conjunctiva of the scleral flap, and that's because of the mitomycin. And you can see that the anterior segment shows you that this complete absence of bleb on the OCT, and that goes with the clinical appearance actually. So, when you do needling, there are various things that happen, under the conjunctiva. And if you take a look at the figure on the top left, this is our patient. There's a pale conjunctiva above the scleral flap, and there is vascularization of the conjunctiva adjacent to it. And when you put a needle under the conjunctiva, what you may expect if the conjunctiva hadn't really stuck to the scleral flap is that the fluid would sort of go underneath the conjunctiva, and then you would lift up the scleral flap. And on the right-hand side, you can see that what can happen when the conjunctiva goes very pale and it's stuck to the scleral flap is that the pressure of the fluid can actually cause micropores to develop in the conjunctiva, allowing the fluid to come out and develop micro leaks. So if one were to do needling, one would have to be extremely cautious in such a patient actually. 1 minute remaining, sir. Yes. So this is, you can see here on the top, you can see the lens volt, and that's very classical, although it's a little bit hard to determine exactly the scleral spur because the iris is in contact with the peripheral cornea. And post cataract surgery, you can see what's happened, that he's developed a negative lens volt, and the total change in the lens volt was about 1.75 millimeter, and the aqueous depth also increased significantly to 3.36. So in left eye, the efficacy of lens extraction reducing IOP was more than 30 millimeters of mercury in presence of a non-functioning bleb. So we often say that just removing the lens reduces the intraocular pressure, and we thought that this was an example where the bleb was not functioning, but the pressure reduced by more than 30 millimeters of mercury just because of the lens extraction. The first few weeks are extremely important if one has to deal with the bleb. A significant pale conjunctiva that is stuck to the surface of the sclera is a challenge for safe needling. The needling of the bleb in the right eye helped to reduce intraocular pressure, but the drainage architecture of the conjunctiva has not yet evolved for long-term expectation of successful filtration. And negative lens volt and total change in lens volt after surgery shows, of course, the efficacy of lens extraction in dealing with one of the possible pathologies. Thank you very much.
Thank you very much. Lot of food for thought. But why would a bleb be flat, and when it lifts up with digital massage, could it be that the ostium was blocked and maybe that would have been the issue?
Yeah, I mean, normally, we believe that it's not really the ostium where the primary block takes place, but that it's under the scleral flap actually that the block takes place. And once the fluid stops going out, then the conjunctiva just sort of tends to settle down on the sclera, which is its resting space. So if the fluid is going out of the scleral flap, then it keeps the conjunctiva elevated actually.
So how soon would you like to do? Would you like to do releasable suture very early, or would you want to intervene with needling right away?
Well, what we tend to do is that it's a stepwise thing. We do a massage and we see if it works. And normally my experience is that massage only tells us that it can be patent, with some pressure. And then we see the patient after another 1.5 hours, and we find out whether the pressure has risen up again actually. If the pressure has risen up again, then that is an indication to us that you go ahead for laser suture lysis actually. If the laser suture lysis works for a little while and then stops working after a few days, and that can happen sometimes, then that means that that is an indication that you go for needling. And needling for us is not merely just, sort of freeing up the conjunctiva from the sclera. For us, it's very important that we free the conjunctiva, but very importantly, we also free the scleral flap from the bed actually to allow the fluid to come out.
Dr. Shailesh, would you have a question?
Given a choice, that's which one you would like to do, a cataract first or the glaucoma surgery first? Because we know we are dealing with angle closure disease.
Yes.
Number one. Number two, many times we may not have all those very wonderful investigative modalities that you nicely captured, AIOS, OCT and all. So in that situation, what clinical features which would like you to err inside on side of a surgery or on side of a medical therapy?
So, I think that, we've had this discussion with some of our panelists also. One is that, for example, the left eye, he came with a pressure of 60 millimeters of mercury. He's already undergone iris atrophy and things like that. And, the disc was really 90% cut with so much ganglion cell loss. So at this point, we think that it is much better that you go for a combined surgery. And I do want to tell you that a lot of people think that in combined surgery, it's very hard to get the bleb to work. But in many cases, you can get the bleb to work in combined surgery in primary angle closure glaucoma actually. And also, therefore, we applied a little bit different rationale for the right eye when we did a combined surgery, that the cupping was very significant. And, we saw what had happened to the left eye. And we thought it was probably good to, opt for a combined surgery also in the right eye. So I think that I also tried to explain that, that just simply cataract surgery in the left eye would have helped us to reduce the pressure by about 30 millimeters of mercury. That's a retrospective assessment based on the intraocular pressure on treatment post-operatively compared to the intraocular pressure on treatment pre-operatively, in presence of a non-functioning bleb. So there is scope for doing a trabeculectomy and a cataract surgery combined in such patients actually.
Dr. Shushmita, I have a question for you. Would you think of even doing a clear lens extraction, if at all, or a very early lens when in an angle closure disease along with trab? Because if you've just done a trab alone, the post-operatively, sometimes some of these eyes, the AC tends to be quite shallow, and it makes the cataract surgery even more challenging. So what are your thoughts on that?
Yeah, so if the pressures are, say, it will also depend on the anterior chamber depth. So there are, for instance, cases like an anophthalmos or a very small axial length with a very, very shallow AC, probably we would make an exception. But usually we don't need to actually take out a clear lens so early in the disease. And by the time there is chronic angle closure causing about 50-60 millimeters of mercury, it's the trabecular meshwork which is damaged, and chronic angle closure does cause a lot of trabecular meshwork damage. So simply removing a clear lens, I don't think would, but probably if it was really shallow and we thought that doing only a trab would compromise it, you might, but a clear lens extraction, at least I've never done it. I've never had a cause to do it. So I don't think it would be required. Depends on the glaucoma completely. Yeah.
Sorry, Dr. Shailesh, I'm going to take one question before I ask you to take. Dr. Tanuj or Dr. Vijaya, what is the role of cataract extraction in a phacomorphic glaucoma? What would you all feel like? What would be would there be any extra special measures, or when would you decide to do a trab also in these cases?
I think a phacomorphic glaucoma, definitely cataract extraction would be the go-to procedure, and you have to preoperatively reduce the IOP and start the patient on steroids. And of course, the expertise for cataract surgery increases because when you open the capsule, you can have a extension of rhexis. So preoperatively, you can reduce the intralenticular pressure by doing aspiration with a needle, and then proceed with a phacomulsification using a dispersive viscoelastic to protect the corneal endothelium. And I think most of these patients do well after cataract surgery, although you need to give a lot of topical medical therapy in the post-operative period to control the IOP. And if you find that there is advanced cupping after surgery or the IOP is not controlled medically, then I would do sequentially later on as a second stage do a trabeculectomy.
Yes. Yes, because it doesn't make sense to operate on a hot eye. And if it is actually just an appositional closure, or if it's just that there is still synechiae is not closed more than 180 degrees. So we could do away without doing a trab too in these eyes. Any thoughts on this, Dr. Vijaya?
Yeah, I think the phacomorphic cataract glaucoma is mainly because of the cataract. I don't think there is a need for the trabeculectomy. And basically, as long as you're missing out on any angle closure glaucoma in that. Otherwise, just removing the cataract, and as Tanuj has put it correctly, and doing a phacomulsification. The trick for doing the phacomulsification is to stain the capsule and debulk the lens before starting the capsular rhexis. Once the rhexis comes out well, the surgery can be simple. So they don't need trabeculectomy. So better not to do a trabeculectomy along with the phacomorphic glaucoma.
Dr. Shailesh?
Yeah, sir, Dr. NANGIA sir has nicely told about the needling part, but how to have a controlled needling, like Dr. Tanuj had nicely shown in papers like AIOS based needling, because we have to do a proper needling and a very extensive needling at times if you have fibrils. Any experience with that, sir?
You know, every case of needling, it appears to be a challenge because, half of the time you're not really able to see, where your needle is actually.
Exactly.
And it's, so you don't know where the conjunctiva is stuck, where it's really thin, where it's going to give way. And then a greater challenge is really to find the edges. If you're not able to see the edges of the scleral flap and you want to go under the scleral flap, then that is a real. So that's something that you tend to sort of, feel with the needle actually. That when you find a rough edge of the scleral flap, if you're not able to see it, of course, if you're able to see it and the conjunctiva comes to your aid, then of course, things are relatively easy actually.
Dr. Tanuj sir, you had experience on that ASOCT based. Are you still following that procedure?
See, I think that is a solution that is only possible in high-tech centers. It's a very expensive, we used to have both the OCT guided slit lamp on the OCT, and of course we have microscope with OCT, but I don't think that is required for regular needling. So I think that has to be done under the observation of the microscope. And if the needling the conjunctiva for an encysted bleb is quite easy, but once you have a scenario where Dr. Nangia showed when the scleral flap is fibrous, that requires a lot of expertise. And unless you see the scleral flap under the microscope, I think it can be a blind procedure and it may lead to hemorrhage and adverse outcomes. Another option is to do a reverse needling. That is, ab interno, you can do with a bimanual with irrigation, and with the intraoperative gonioscope, you can visualize the ostium and you can do a bit of needling there if the ostium is stuck, or you can even put in the instrument and raise the flap, especially if it is like 6 weeks or in the early postoperative period. So that is another option if under the microscope the scleral flap is not visible. But on the whole, if you see the long-term prognosis after scleral flap is fibrosed, the long-term prognosis of needling is not good. So these flaps tend to fail. And one more point, I think when you do needling alone, that may not be sufficient. You have to give some antifibrotic therapy along with needling, such as 5-fluorouracil or diluted mitomycin C, because it's a failing bleb. So just maybe plain needling may not be sufficient. Thank you.
Dr. Shushmita, what would be a follow-up schedule post YAG-PI? Like, would you believe there's a role of ASOCT, and what would be the most important index which you would see on ASOCT?
Okay, so just one comment about the needling. I'll just finish that. So clinically, we've also seen that if the needling works best if there is fluid under the scleral flap, because usually it's not a nice thing to go blindly under the scleral flap. Usually the needlings are done subtenons. And if on gonioscopy, you can see fish mouthing of the sclerostomy, we found that to be a very good indicator of some fluid under the scleral flap, and those blebs are likely to do better than those in which it's just a straight line, which means there's no fluid going into the underneath the scleral flap, and doing a subtenons needling in those cases isn't going to work. So that's just one small caveat. Okay, regarding the post-op follow-up of YAG-PI, of course, we need to see the intraocular pressure, of course, and the patency of the YAG-PI. That's the first thing. We don't usually use an ASOCT either pre or post. It's all gonioscopy based. And post YAG-PI, it's very important to do a gonioscopy and see to what extent the angle has opened up. But the easiest clinical indicator would be the intraocular pressure. And the two things that to look for if the IOP is not controlled is the patency of the PI and whether there's synechial closure. But once there is a patent PI, I think the principles of angle closure are much the same as open angle work. So we would start with prostaglandins anyway.
Thank you so much. Thanks a lot, Dr. Vinay Nangia. That was a wonderful case which you showed. You stay on with